Everyone, and I think we'll go ahead and get started. Love to thank Chris Holder, our IT person, for the music. Thank you very much, Chris. Hi, everyone, and welcome to this Evenings with Genetics webinar on navigating new therapies, 21st century treatments for genetic disorders. We are thrilled to have you all this evening, and it should be a really fascinating talk. I'm Susan Fernbach. I'm the director for the Evenings with Genetics seminar series, and this is our 16th year for the series, and it's sponsored by the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital. If you would like simultaneous interpretation to Spanish, please use the interpretation button at the bottom of your screen, and you will be able to hear this presentation in Spanish. And simultaneous translation is possible thanks to Mercedes Alejandro. And we ask that you write your questions in the Q&A box, and we will get to all of the questions at the end. So please do so. So we really have a huge thanks to our donors, Genetics and Genomics Services, as well as Nancy Parkhurst. We're grateful for this support, which sustains the program. So I have the pleasure of introducing our speakers tonight, Alicia Turner, Dr. Reid Sutton, and Samantha Crawford. And I will start with Ms. Turner Sutton, who will be our first speakers. Alicia Turner is a nurse practitioner and assistant professor of molecular and human genetics at Texas Children's Hospital and Baylor College of Medicine. She spent the majority of her first 8 years of her nursing career as a neonatal ICU nurse, where she often cared for patients with genetics disorders. And during that time, she gained an interest in genetics. So she was happy to be the first nurse practitioner hired by our department, where she's worked for almost 5 years. Alicia cares for patients with metabolic and skeletal genetic disorders with a particular interest in lysosomal storage disorders and osteogenesis imperfecta. She runs the genetics infusion program and manages many new therapies, in addition to being involved in research, which includes rare new therapies for rare conditions. And we'll also be hearing from Dr. Reid Sutton, who's a professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. Dr. Sutton is the director of the Inborn Errors of Metabolism Service at Texas Children's Hospital, and his clinical areas of interest are in caring for children with inborn errors of metabolism, as well as children with abnormalities in bone and cartilage development. He's been the principal investigator for research studies in these areas and is making scientific contributions in the characterization and discovery of a variety of genetic syndromes, including White-Sutton syndrome. Dr. Sutton serves on the medical advisory board for the Osteogenesis Imperfecta Foundation, as well as the White-Sutton Syndrome Foundation. So please give a warm welcome for our first two speakers, and hopefully from the warmth of your. Thank you, Alicia and Dr. Sutton.
Thank you so much, Susan, for that intro. I'll go ahead and share my slides with you all. So today I was hoping to talk to you all about new therapies that are coming out for genetic disorders. I think something many of us know is that genetic disorders historically haven't had a lot of medications or other treatments to treat them. You would be diagnosed with a genetic disorder and you would be managing the symptoms rather than treating the disorder. So our objectives for tonight are to discuss new therapies for genetic conditions that previously had no effective treatment or for which new treatments are now available, to discuss new therapies, including gene therapy, in the clinical trials that are going on at Baylor and Texas Children's Hospital, and to learn where and how to learn about the research and clinical trials that are going on. So in terms of disclosures, I have none. And I wanted to start off by talking about rare disorders. So 72% of rare diseases are genetic. So you can see a vast majority of rare diseases have a genetic component to them. This is important because rare diseases are often underdiagnosed, misdiagnosed, underrepresented, and underfunded. Why does this matter? We think about diabetes or hypertension. There's obviously a lot more individuals affected by these conditions, but some people don't realize just how common rare disorders are. So they say that there's about 300 million individuals worldwide that are affected by rare disease. I read a statistic that this would make up the third largest country in the world if we had put all those individuals in one area. I've seen different figures, but anywhere from 4 to 5% of the world's population have a disorder that's considered rare. And there have been over 6,000 unique conditions identified. So at Baylor College of Medicine and Texas Children's Hospital, we have clinical studies that are ongoing now. And this is a graph of the last 5 years, and you can really see how things have really picked up in terms of clinical research that we're doing. And I wanted to introduce Dr. Sutton now, who will be giving some information on a Baylor-specific led clinical research trial.
Thank you, Alicia. Good evening, everyone. So I'm going to talk with you, as Alicia said, about a specific treatment trial that we initiated here at Baylor College of Medicine and Texas Children's Hospital regarding a new therapy for a condition called osteogenesis imperfecta. And I'll abbreviate osteogenesis imperfecta, OI, from now on for simplicity. So this is the most common inherited bone disease in children. It has a prevalence of about 1 in 15,000. So again, as Alicia had mentioned, qualifies as a rare disease. This is a disorder of connective tissue, and that includes bones or the skeleton, particularly with low bone mineral density, recurrent fractures or broken bones, and as you can see in the x-rays over on the right side of the slide, deformities, including things like bowing of the long bones in the legs that are shown in that first image, with the femurs and the tibias having bowing. And then over on the right side, the curvature of the spine, which is scoliosis. And there are other features associated with OI as well, because this is not just a bone disease, but a connective tissue disease. And this includes dental abnormalities termed dentinogenesis imperfecta that you see in the image here, which is characterized by a poor quality of the section of the tooth underlying the enamel called the dentin, which gives this grayish brown or opalescent appearance to the teeth as shown. Hearing loss, particularly in the mildest form of OI, is common. And then we also know and increasingly find that there are various other features, including both muscle weakness, as well as lung abnormalities and poor lung function that are seen in OI. The vast majority of individuals with OI have changes in genes that encode for a particular connective tissue protein called type 1 collagen. And those two particular genes are called COL1A1 and COL1A2. And then there are a minority of individuals with abnormalities in other genes that cause problems with how the structure of this type 1 collagen connective tissue molecule is processed and how it's transported to where it needs to be within the cell and connective tissue. Presently, there are no approved therapies to treat osteogenesis imperfecta in the United States by our US Food and Drug Administration. There are a variety of therapies that are presently used, and these include disorders that act on osteoclasts or cells that remodel bone, and disorders that act more on osteoblasts that are, pardon me, that are cells that lay down new bone. And we'll talk a little bit more about this in a upcoming slide. Here in our department chair, Dr. Brendan Lee, has had a long-standing interest in bone and connective tissue disorders. And particularly had discovered the first of these rare genes that are involved again in the processing and transport of type 1 collagen. And over the course of his research, one of the graduate students and postdocs in his lab, Ingo Graffe, identified that there was an abnormal signaling process that was seen. So one of the things that we see in many rare disorders is that there can be changes that can result in abnormalities of what we would call signaling. So if you think about the old-timey game called telephone, and I don't know if I'm too old to relate this to everyone, and maybe everyone doesn't know this, but there used to be an old-timey game called telephone where one person would start and whisper a word or a sentence to someone in a circle, and then that person would then be required to whisper it to the person to their right, and that would go around the circle. And they were not allowed to ask questions if they didn't understand it, and you would kind of see what at the end it came out. And often the fun of the game telephone was that whatever was heard at the very end of that whispered circle was very different than what had started out at the beginning. And so this can be true in genetic disorders as well, where you have these communications that need to go around within the cell to tell various things, whether it's connective tissue proteins or other sorts of things that tell them kind of what to do. And so also within this process, just like within that old-timey game telephone, there can be mistakes that are made. And so one of the findings here was that when you have abnormal type 1 collagen, that this causes a problem in this communication that we see within the cell. And the particular communication error is shown here on the left. So TGF beta, transforming growth factor beta. And you can see that there is this communication from this to what's called a receptor, which is on the surface of the cell. And then once inside the cell, these other sorts of communicators that are shown in the blue ovals that are the different SMAD proteins, SMAD2, 3, and 4. And so one of the things that we can do to assess how this communication is happening, and that Dr. Lee did in his lab, is to look at, again, like the game telephone. So if you start off with what comes in, looking at what's coming out, and is what's coming out the correct message. And so what was seen in various forms of osteogenesis imperfecta is that there was actually an increased communication. So what you see is that these red bars here, so wild type is kind of a normal mouse, and these levels of what are called this kind of phosphosmad are shown over here. And then in the red bars, these are mice with various forms of osteogenesis imperfecta. and that you can see they have an increased communication. So this was the first inkling that there was some sort of communication error that was caused by changes in type 1 collagen. And indeed, when you looked at mouse models again of osteogenesis imperfecta, so you see the first column on the left that's labeled WT, that stands for wild type. That's a normal mouse. And you see these are sections through a vertebral bone, and as well as the lung at the bottom. And you see that in the lung, there are these air spaces, and you see in the bone that within the bone, there are these kind of bridging pieces of bone within the vertebrae. When you look in that middle panel, you see that these are mice with osteogenesis imperfecta, and you see they have much less of that bridging bone in their vertebrae. And notably in the lung, you see that there is much less of this red that is a cellular air sacs, and much more white that is these very enlarged open air sacs. And then in the far right, what you see are mice with OI that are treated with an antibody against this communication related to TGF-beta or transforming growth factor beta that we talked about on the previous slide. And you see that when you treat these mice to fix that communication problem, that now you have much more of these bridging connections within the bone that provide bone strength. And similarly, again, compared to that middle panel, you see at the bottom that the lung spaces look much more normal in size, and they're not as enlarged anymore. So based upon this mouse work that Dr. Lee did in his lab, we wanted to try to translate this to a treatment trial for humans. And we did this through our Brittle Bone Disease Consortium. So this is a project that's funded by the National Institutes of Health. We are the coordinating site for this study of osteogenesis imperfecta. And you can see that in addition to our being the lead site, we have a number of very important collaborators across the United States that are also clinical sites within our network. And some of our orthopedic surgeons that are collaborators within this brittle bone disease, rare disease clinical research network were very helpful in obtaining bone samples from individuals with OI who are having surgery. So if they had like a broken bone, for example, and needed a rod placed or other sorts of surgeries, they would obtain for research bone samples for us to try to show that in humans, that this increased signaling of TGF-beta or abnormal kind of communication like we saw in the mouse was indeed present in humans. And so in the graph over on the right, you see this level again of these downstream communications called SMADs. And you see that in non-OI individuals, the bone samples that were obtained had this sort of level. And then when we looked at individuals with severe form of OI type 3, shown over on the far right, that they had much higher levels of these downstream communications. And so this supported what was seen in the mouse model and also informed us that if we're seeing this in humans, like we see in mice, that maybe treating the humans with this antibody to TGF-beta could also help them just as it had helped the mice with bone density and changes in the lungs. So this project within our Brittle Bone Disease Consortium was led by Dr. Sandesh Nagamani, shown here on the right, who is a great colleague. And so not to go into too much detail, but just to let you know that there were 2 different doses of this antibody that's called fresolimumab that was used. This is what is called a phase 1 study. And so while we do collect some data about how effective this is, the main goal of this and why we use 2 doses is to determine safety. So what we saw in regards to safety is that in general, this antibody for TGF-beta was safe. There were no serious adverse events, either in the lower dose or the higher dose groups. As I mentioned before, bone undergoes a remodeling process, and you have in yellow these cells called osteoclasts that remodel bone, and in blue these cells called osteoblasts that build new bone. And so again, these different medications can be used to treat and modify the activity of these different cells. So what we saw in the treatment trial was that in moderate OI, that the lower dose of this antibody, fresolimumab, increased but did not help much in severe OI. Similarly, the higher dose increased bone density in the spine, as shown here in the right in the 4 milligram dose, in the moderate form of OI, but not in severe forms of OI. And so again, all of this was recently published in the Journal of Clinical Investigation from our Brittle Bone Disease Research Consortium. We are very excited to be in discussions with a biopharma company who is interested in proceeding with further clinical trials of this medication to try to treat osteogenesis imperfecta. So thank you, Alicia, and I think we're back to you.
Thank you so much for that information. And I'm going to transition back into other new therapies that are not exclusive to Baylor College of Medicine and Texas Children's Hospital. So the number one thing that often people ask me about is gene therapy. What is it? Gene therapy treats or prevents disease by correcting the underlying genetic problem causing the disease. Gene therapy techniques allow clinicians to treat a genetic disorder by altering a person's genetic makeup instead of using medications or other therapies. Gene therapy aims to introduce a new gene into cells to help fight a disease, or introduce a non-faulty copy of a gene to stand in for the altered copy causing a disease. And one example we're going to discuss tonight is gene therapy for Hunter syndrome. The specific therapy is RGX-121. It's designed to use the AAV vector to deliver the human iduronate 2 sulfatase gene to the central nervous system. So there's a picture on the right here, and it may seem very complex, but the body can use can accept certain viruses into it, and the new gene is packaged into a virus that can then deliver the gene to different areas of the body. And tonight we'll actually be hearing from a parent of a child who has received this specific therapy. So this is Alexander, and he has been diagnosed with mucopolysaccharidosis type 2, which is also known as Hunter syndrome. Hunter syndrome is caused by a gene mutation in the IDS gene. This mutation causes a deficiency in an enzyme that breaks down large sugar molecules in the lysosomes, and the lysosomes are a part of the cell. The buildup of these molecules in various tissues and organs causes the symptoms of this disorder. And this is an X-linked disorder that occurs in 1 to every 100,000 to 170,000 males. So on the right is just how the disorder is inherited. Again, it's X-linked, so it is passed from mother to son. Typical findings include coarse facies, macrocephaly. So these are all a little bit complex. I'll break them down for you. So a large head, hydrocephalus, which can be fluid on the brain, corneal clouding, which is clouding of part of your eye, papilledema and retinopathy. These are problems inside your eye. Frequent URIs or upper respiratory infections and ear infections, enlarged adenoids and tonsils, obstructive sleep apnea, irregularly shaped teeth, and gingival hyperplasia, thickening of cardiac valves, hepatosplenomegaly, so that's enlargement of your spleen and your liver, umbilical hernia, chronic diarrhea, large joint contractures, so stiffening of large joints in your body, dystatosis multiplex, which is some findings that are changed on your x-ray, hip dysplasia, carpal tunnel, and developmental delay. So what does this gene therapy do? This gene therapy delivers the gene encoding the enzyme, so the gene that would help make this enzyme that is deficient within the cells of the central nervous system to provide a permanent source of secreted IDS beyond the blood-brain barrier. This is thought to potentially prevent the progression of cognitive deficits that otherwise occur in Hunter syndrome patients. And subjects are currently being enrolled to a phase 1/2 clinical trial of intracisternally delivered RGX-121. RGX-121 has received orphan drug product, rare pediatric disease, and fast track designation from the FDA. So you can see below a viral vector is being used, and a copy of the functional IDS gene is within the viral vector. And when it is injected intracisternally, the gene therapy can actually be introduced to the patient's own system. And hopefully the thought is that the body will make enzyme that it's deficient in. So we do have therapies currently for Hunter syndrome. The current FDA approved Hunter syndrome therapy is Elaprase. It's an enzyme replacement therapy, but it does not cross the blood-brain barrier. So our bodies are smart, and there's a protection in the blood flow that goes to the brain that certain molecules cannot enter, and the drug is one of them. So with the viral vector, the virus can actually cross that barrier and enter the brain and hopefully be impactful on the disease process. And clinical trials like RGX-121 offer new advancement in the care of people with Hunter syndrome. Another topic which has been discussed previously on Evenings with Genetics that I wanted to touch on is genome editing. And this is often known as CRISPR-Cas9, and it uses a different approach to correct genetic differences. So we talked about introducing a functional copy of a gene within a virus, but this would actually be a little bit different. So instead of introducing new genetic material into the cells, genome editing introduces molecular tools to change the existing DNA in the cells. So that would be actually editing your own DNA or the patient's own DNA. Genome editing is being studied to fix a genetic alteration underlying a disorder so the gene can function properly, turn on a gene to help fight a disease, turn off a gene that is functioning improperly, or remove a piece of DNA that is impairing gene function and causing disease. So I'm just linking here to the previous discussion that you can actually find on Evenings with Genetics. You can Google Baylor Evenings with Genetics if you forget later and access all the previous recordings. And this particular recording is called CRISPR and the Genome Editing, Treating Human Disease and Ethical Considerations. And it was given by our own Jason Haney and Sarah Ewingard, who are both employees of Baylor College of Medicine. So with gene therapy and gene editing, there have been a lot of ethical concerns that have come up. One of them, first and foremost, is who decides if the use of these therapies is appropriate. So who gets to say if this is a gene that we need to edit, if this is something we need to fix, and if this is ethically appropriate. Could these therapies be used not only to correct disease-causing gene alterations, but also to control human traits like height, eye color, etc.? That's something that people are often very concerned about. Cost and availability, will these therapies be distributed in a just and equitable way, or will cost be prohibitive? And then the last thing to think about also is that we really don't know the long-term side effects of these therapies. They're going through trials and they're safe, and they've not, had any sort of side effects that cause a trial to stop if they're coming to market or to not come to market. But again, we don't have 10, 20 years of data on these therapies yet. And besides gene therapy, genetic disorders now have many other emerging pharmaceutical therapies for genetic conditions. And I'm going to highlight a few that I think have been pretty revolutionary within the last several years that I have been in genetics. So just shy of 5 years, and all of these medications have come to market right around when I started in genetics. So I wanted to start off with Voxogo, and this is a medication that treats achondroplasia. It's a C-type natriuretic peptide, and it's indicated to increase linear growth in pediatric patients with achondroplasia aged 5 years and up, whose growth plates are still open. The drug has received FDA approval in 2022, and the drug trials for this particular drug actually took place here at Texas Children's Hospital. And we now have patients who are being prescribed these medications out of our clinic, as well as the patients who have been in the trials that have chose to continue on with the extension study here at Texas Children's. These particular efforts are being led by Dr. Carlos Bacino and Diane Bari, who's a nurse practitioner at genetics at Texas Children's Hospital, Baylor College of Medicine. Voxogo is a daily injection that can be given at home. So it's easy for patients. That's debatable with children, but it's something that can be done in your own home. In patients with achondroplasia, endochondral bone growth is negatively regulated due to a gain of function mutation in fibroblast growth factor receptor 3. So because of this gene mutation, it negatively affects bone growth. So actually binding of the drug to natriuretic peptide receptor B antagonizes FGFR3 downstream. So it helps to work against what this is causing for the bone. So as a result, Voxogo, like CNP, acts as a positive regulator of endochondral bone growth as it promotes chondrocyte proliferation and differentiation. So there's a lot of really, if you're not into bone, a lot of words that you may have never heard before, but the takeaway for this is that there's linear growth in these patients with achondroplasia, which most people are familiar with, which is a type of disorder that causes smaller stature. So in animal models with open growth plates, Voxogo administration resulted in the promotion of chondrocyte proliferation and differentiation that led to a widening of the growth plate and subsequent increase in skeletal growth. In the mouse models, a partial or complete normalization of dwarfism phenotype was observed. So in the mouse models in particular, we did see that, or the studies showed that there was some normalization of the bone issues that happen in achondroplasia. And the next therapy I want to speak about is Gallifold, and this treats Fabry disease. Unlike achondroplasia, you may not have heard of Fabry disease, but it's another X-linked disorder that can cause a multitude of issues for patients, most serious of which include renal disease and failure, left ventricular hypertrophy, so enlargement of your heart, strokes, and pain crisis, and particularly in the hands and feet. It's a disorder that results from absent enzyme activity in lysosomal enzyme A, enzyme A galactosidase A. As a result of this enzyme deficiency, GL3 builds up in the body. So there's a genetic mutation which causes less of an enzyme to be made, and then something builds up in the body that should have been broken down by that particular enzyme. Gallifold is a small molecule, alpha-Gal A pharmacological chaperone that reversibly binds to the active site of alpha-Gal A and stabilizes the protein. So your gene is not making the proper protein that it's been assigned to do. And this medication can actually work to stabilize that protein that is not working correctly, and then chaperone it to where it needs to go to do what it needs to do in the body. So it restores a normal pathway for tracking amenable alpha-Gal A in the lysosome. And it's a capsule that's taken every other day. And I should mention that there is an alternative therapy. The first therapy that came out for this is an infusion that is given in an infusion center or at your house every other week. And for some patients, including pediatric and adult patients, this can be quite inconvenient and interfere with school and work. So this is for 18 and above, but is an alternative and makes life a little bit easier for patients who have the amenable mutation for this particular drug. So most people will meet criteria to take the drug, but some mutations prevent patients from being able to take this particular therapy. And we have STRenzik that was released for PKU. So mutations in the PAH gene cause PKU. And this particular gene provides instructions for making an enzyme called phenylalanine hydroxylase. This enzyme converts the amino acid phenylalanine to other important compounds in the body. Proteins from the diet are then not processed effectively. And as a result, this amino acid can build up to toxic levels in blood and other tissues. So some people previously called our newborn screens PKUs, and this is screened for on newborn screens. And as you can imagine, can be a tremendous limitation for patients as your diet has to change tremendously. It's easy to kind of control an infant's diet, but then when children get older and they're on a very strict diet, this can really be difficult for them. And then, of course, transitioning into adulthood with these same restrictions. This medication, again, is for adults, but STRenzik is an injectable therapy. It's a phenylalanine metabolizing enzyme. So it actually metabolizes the Phe to reduce Phe concentrations in adult patients with PKU who have uncontrolled blood Phe concentrations. This allows patients with PKU to eat a normal diet, including protein. It is titrated eventually to a daily injection. So before this, really there was nothing you could take to kind of resume a normal diet without any restriction. And there is also a drug called STRenzik, and it's for the treatment of hypophosphatasia. It's an enzyme replacement indicated for treatment of perinatal or infantile and juvenile onset hypophosphatasia. This medication is given to adults, but is not yet approved specifically for adults. And it's given subcutaneously, either 3 times a week or 6 times a week, depending on how patients tolerate the drug. So this medication, again, is a great drug that kind of gets to the root of the problem. Patients with this particular disorder, hypophosphatasia, are missing an ALP enzyme. And this drug actually replaces that missing enzyme, which frees phosphate to bind with calcium and mineralize the bones. And this is a picture of baseline versus 24 weeks of treatment. A patient who is obviously an infant. And you can see on the left side, the bones are obviously very thin, undermineralized. And then on the right side, there's been a drastic change in the appearance of the bone. So this was actually during the drug study for this particular drug. And lastly, there's Chrisvita for X-linked hypophosphatemic rickets. This disorder is also a bone disorder and is really characterized by bowing of the lower extremities, as you can see in the pictures on the bottom. It's caused by a mutation in FEX, and this mutation causes excess FGF23, which actually causes issues with renal phosphate reabsorption and intestinal phosphate absorption. So there's phosphate wasting in this condition. Chrisvita is a human monoclonal antibody that binds to and inhibits the biological activity of FGF23. So FGF23 is causing the problem because of the FEX mutation, and this medication can actually correct that. And this medication is given subcutaneously once monthly for adults and twice a month for pediatric patients. So I hope that gives you an idea of just how revolutionary treatments are getting, and gives some hope and some interest to people around what can be done for genetic disorders. And that's not an exhaustive list, but just some of the more recent drugs that have come out. We're using at Texas Children's Hospital and Baylor College of Medicine. So I wanted to touch on, lastly, what is the best way to learn about these trials? How to learn about these ongoing research trials? Because I know as a nurse, before I became a nurse practitioner, I really wasn't aware of what trials were going on, how to access them, and how to get my patients involved or interested or just informed about these trials. So some ways to access these trials that are coming out are groups specific to the condition. So for example, the OI Foundation or the MPS Society, clinicaltrials.gov, which all clinical research is required by law to be registered under, and then NORD, which is the National Organization for Rare Diseases. When accessing clinicaltrials.gov, I wanted to give everyone a better idea of what it looks like and make people comfortable with kind of using the site and how they could find information on the particular disorder they're looking for. So this is just the home screen for clinicaltrials.gov. As you can see, it opens up nicely and is easy to see how to find a study. You can look for recruiting studies or all studies. You can enter the disease you're looking for, any terms in specific you're interested in, and what country. You can limit to your own country or leave that open. There's also a very nice advanced search, which if you're really looking in particular, say for a patient of yours or for a family member or loved one, you can put in their age, you can put in their disease, what type of study you're looking for, and what type of, if it's a phase 1, phase 2, phase 3, how far along you'd like the trial to be. You can kind of search from there, because it can be quite, depending on the condition, you can get a lot of results. And so this helps kind of narrow it down. The National Organization for Rare Diseases, which can be found on rarediseases.org, is also a really great resource. Their mission statement is NORD, a 501c3 organization, is a patient advocacy organization dedicated to individuals with rare diseases and the organizations that serve them. NORD, along with its more than 300 patient organization members, is committed to the identification, treatment, and care of rare disorders through programs of education, advocacy, research, and patient services. So I wanted to show where you could find more information on clinical research and research studies on NORD. So again, when you open up NORD, there's multiple tabs, and you can kind of choose which you are, a patient or family, a clinician, patient organization. You see here under patients and families, there's information on clinical trials and research studies. This is also an alternative if you're looking to find out more about research trials. And then I want to highlight under that arrow as well is the Rare Disease Centers of Excellence. So that's how you would locate a Rare Disease Center of Excellence. Baylor in particular in 2021 was designated as a NORD Center of Excellence. So that's our department, both Dr. Sutton and I. And this particular initiative, the NORD's Rare Disease Center of Excellence program, is the first ever designation program dedicated to all rare diseases and the patients impacted by them. The centers that form the NORD Center of Excellence network will work in partnership to share expertise, advance education, define standards and protocols, and shape the field of rare disease care, ultimately enabling rare disease patients to better navigate their diagnostic journey and find qualified medical homes for their complex medical conditions. So I wanted to highlight that too, as well, if you're feeling overwhelmed by navigating the clinicaltrials.gov or finding a research study on your own or getting information, you may consider a rare disease center of excellence. See if there's one local to you that you could get more information from and see a specialist in. And then lastly, I really want to highlight some of the condition-specific groups that offer support, education, and information on clinical trials. If there's one available for the rare disease or the disease that you have, they really can be a phenomenal source of not only support for patients and families, but also education and networking. Sometimes some of my patients have been talking to other families within their groups and have details that even I haven't heard yet. So it's quite amazing how this networking can really change people's lives and share information and support. What I wanted to kind of summarize at the end of this talk is that gene therapy continues to be an exciting and innovative way to treat genetic disorders. And this includes CRISPR and Cas9, genome editing, and it continues to be developed with great potential. Again, there's a talk that previously occurred that you can listen to on our recordings if this interests you. If gene therapy is not something you're interested in, or you just wanted to know more, there's going to be more medical advances in therapeutic agents. So it's not just limited to gene therapy and CRISPR and Cas9. There are injections, infusions, medications, and pills that are coming out as well. All new therapies begin as clinical trials. So every drug from these new therapies that are for gene disorders or rare disorders to medications for hypertension or high blood pressure, they all start as clinical trials. And these trials are all accessible to the public. Clinical trials really drive our treatments forward. So if we want new treatments, we really have to support these trials and participate and be aware of them. So access to these new therapies and ongoing trials is essential for clinicians, patients, families, and loved ones. And if you feel like navigating the whole process alone is a bit much, NORD and NORD Centers of Excellence can help bridge the knowledge gap. So if you feel like you want to speak with someone or go to see a center of excellence, that's always a possibility for yourself, your loved one, or your patient. Really, the takeaway too is that rare and genetic conditions are collectively, they're not rare. So they really deserve our awareness, our attention, funding, and dedication of research to further the development of effective treatment for them.
We do have some questions here, and some of those, and I know that Dr. Sutton, it looks like you've answered a couple of them, but there is a lot of interest in knowing about White Sutton syndrome and therapies for that. And then also if you and Alicia Turner see patients for consultation.
So I know Dr. Sutton definitely does specifically on Sutton White. I don't see Sutton White if that's what is being referenced. I know he's available. And I, in particular, see a certain group of disorders, skeletal disorders and metabolic disorders. But I think it just depends on what in particular patients are looking for, or families.
Correct. And I typed responses, and I think that, so as Alicia had said earlier, I think these NORD Centers of Excellence for Rare Disease are really great progress in helping families identify centers that really kind of specialize in this. And it's really more than just a particular disease. So in the application process, it really ranged very widely from not just kind of diagnosis, but being able to offer things locally at the institution, everything from genetic testing to medical therapies, research, transplant, heart transplants or other organ transplants and all sorts of things that are very important in rare diseases. And so the application process and the review that NORD did was really very comprehensive in ensuring that each of these centers weren't just kind of focused on one particular disease, but really had a very broad expertise in rare diseases. Again, everything from kind of medical, surgical, counseling, also social support, all sorts of things that we know are very important for individuals with rare disease navigating that sort of process. And so again, I think that's a great resource. Certainly, as Susan mentioned, I typed a couple of responses for White Sutton syndrome. Unfortunately, no gene therapy, but again, this is a bit tricky for many rare diseases. And so I think we're really just beginning the process of that, as Alicia had discussed. There is a clinical trial that I've been in discussion with a colleague in Italy that he's starting a clinical trial for White Sutton syndrome. It's using a seizure medication that is not approved in the United States, but that does seem to hold promise based upon study in mice with changes in this gene POGZ. And so I discussed earlier, again, kind of the importance of when we're starting new therapies, before we kind of risk children or humans with a particular condition and expose them to risk from a particular treatment, and ensuring that it looks like it would be safe and effective based upon, again, kind of mouse or other sorts of non-human studies that had been done. And so again, this medicine usually used to treat seizures is starting there in Italy. And again, I've been in communication with them and hopeful that they'll see some good progress with that.
This is really remarkable, and what you all have presented tonight is remarkable. And certainly for me, having been a genetic nurse for many years, to see that there are all of a sudden so many therapies like this is incredibly exciting. And I think, Ms. Crawford, to hear from you and your experience, this just gives so many people hope. So I really thank you for presenting. This is an unbelievable kind of thing to be happening after so many years. So I am completely thrilled about this. Let me see if there are some other questions in here. And yes, okay. I guess there is one. Read that the POGZ gene primarily expresses itself during fetal development. Does this mean that the damage is essentially done early on, and gene therapy won't be as effective for WSS, or with the insertion of an intact copy of the POGZ gene correct certain things, such as hypotonia, for example?
Yeah, so let me kind of address this a little bit more broadly than that question, but it certainly applies to that question. So I think this is one of the challenges that we have in genetics, is that that for many genetic disorders, certainly there are some genetic disorders where it's very clear that the genetic change is really causing a problem in early development, meaning kind of when the infant is in the womb before birth, that there are already those sorts of problems. And so a good example of that would be, a common birth defect, like let's say cleft lip or palate, where, it's very clear that that's a developmental process that occurs before birth. And so, trying to do gene therapy after birth for cleft lip and palate is not going to be helpful, because, that's a developmental process that's already occurred. But for many of these neurodevelopmental processes, I think that many times it's really very unclear. And certainly one of our colleagues here, Huda Zogby, who runs the Texas Children's Neurological Research Institute, has shown for a condition called Rett syndrome that primarily affects girls, as well as other disorders, that it really does, in disorders where we thought maybe that, oh, well, it really is like a developmental process, and like once the injury or damage has occurred, there's like no going back. That I think there is increasing evidence in many of them that it maybe is not really kind of a damage at one point in time where there's no going back, but but that in many cases it is likely that it is kind of an ongoing problem with how the nerves are working. And so that if we could again have some sort of gene therapy, Alicia talked a lot about very interesting therapies in regards to how communications happen within the cell, how cells communicate with one another, or other sorts of treatments. And so I do think that, we really, at this point, for many disorders, particularly again, these sorts of neurologic disorders, whether that's intellectual disability or seizures or other things, we don't really have a great understanding of, like, is it like something that happened and you can't fix, or is it this kind of just abnormal cellular function that's ongoing, that if you could just fix that, that it could lead to, improvements again in intellectual disability or seizures or those sorts of things.
There's great hope, and I think there's going to be some great changes in the 21st century. So this is incredibly exciting. I really would like to thank all three of you for speaking tonight. Alicia, thank you for all of the various therapies that you presented, and also for letting people know that we have a whole bank of recordings, previous webinars on a whole variety of topics. So please go to our Evenings with Genetics website and you will see that as well. So thank you, Alicia Turner. Thank you, Dr. Reid Sutton. Thank you, Miss Amanda Crawford. This has been a remarkable evening. Very exciting. So good night, everyone.
Hi, good night. Thank you so much.
Thank you. Stay warm, everyone in the Houston area.